I'm Mary Fox. I'm currently a nursing professor at York University in Toronto, Ontario, Canada. I also worked many years as a nurse and a nurse manager in acute long-term care facilities. And my program of research focuses on older adults functioning during their illnesses and recovery. My conference presentation that I gave yesterday was about exploring beliefs on rest and physical activity and helping older people stay functioning during their illnesses and their recovery. So the key points from my presentation were I gave a little historical overview of bed rest, and we learned from that since the 1950s, getting patients up out of bed at a minimum has been a recommended part of daily care. But we also know that many hospitalized older people still spend quite a bit of time lying down on stretchers, in beds, and reclined chairs. And studies have found that older people in hospitals spend between 71 and 83% of their time in hospital lying down, and with up to 40% staying in bed for at least 24 hours. We identified that this is a starting point in a trajectory to what we call bed rest dependency, which is characterized by a person's compulsion to return to bed soon after getting up, self-limiting their upright physical activity and or refusing to get up altogether. And some of the patients that I spoke with in complex continuing care facilities in Canada, which are similar to skilled nursing facility in the States, told me that they wanted to actually get up, but they couldn't tolerate it. This one woman said to me, you know, Mary, you'd think staying in bed all the time would make you feel less tired, but it's just the opposite. It makes you feel more tired. And she told me how she tried to get up the other day to go to the chapel, but she couldn't stay up more than an hour, and she begged the nurses to put her back to bed. So this one woman wanted to get up, but she actually wanted to get up, but she couldn't tolerate it. So it really affected her quality of life. So what I learned from that is we need to stop bed rest dependency before it begins, because once it's established, it's really very difficult to undo. And we know from the space studies, studies that were conducted by NASA, for example, that bed rest pretty much affects just about every system in the body, but it has its most profound effect on the cardiovascular system. Adequate functioning of the cardiovascular system during walking and upright activity is really dependent on exposure to gravitational stress along the longitudinal axis of the body. And the horizontal position of the bed provides a reduced gravitational stress to which the cardiovascular system actually really quickly adapts within 2 to 4 days. The problem is that once bed rest has ended and the person gets up, the cardiovascular system has difficulty reversing this adaptation. Its compensatory mechanisms fail to adequately increase cardiac output. There's insufficient delivery of oxygen and nutrients to the tissues, and the person experiences orthostatic symptoms such as dizziness, tiredness, and weakness when they get up. In the space studies, these symptoms were defined as the hallmark of bed rest deconditioning and the most significant determinants of self-limited upright physical activity after a period of bed rest. The space studies identified that the severity of the symptoms is proportional to the duration of bed rest, and that recovery takes up to 3 times the time spent in bed. That means for each day in bed, up to 3 days of recovery are needed. When you factor in the time a person might have spent lying down before they come into the hospital, recovery times can be quite long. So we need to start ambulating patients early after hospital admission. But sometimes this can be difficult because some patients may be afraid to get up, or they may think rest is more important to do while they're in hospital. So understanding the perceptions and the preferences that someone has about physical activity interventions, such as exercises to prevent orthostatic intolerance, is important, because we know that beliefs tend to predict behavior, and as healthcare, help them to meet their goals. Sometimes this may involve addressing patients' perceptions and fears that may be undermining their recovery. Our systematic process, which was developed by one of my team members and has been validated in research, it involves describing the intervention, so what the patient needs to do, how often, how much, and what other research has found about its effectiveness and its risks and side effects, if there are any. Then we engage patients and sometimes their family members in a discussion. And this process can also be used in clinical practice to assess perceptions about physical activity interventions in terms of their appropriateness and effectiveness, so will the intervention work, and the convenience and risks. Understanding whether patients perceive an intervention as acceptable or not is important, because research shows this influences a person's engagement in the intervention and their adherence to it. In other words, the questions can help you identify and better understand a person's beliefs that may be preventing them from engaging in activity, so that you can respond accordingly. After describing the intervention, you can ask, what do you think? Will it work? If not, why not? Is it appropriate? If not, why not? Will it be easy for you to do? If not, why not? Are you concerned about any risks or side effects? If so, tell me what they are. Based on our synthesis of prior research, here are some of the strategies that can be used to encourage activity. And I've organized them as responses to some of the most common rationales that people have put forward to us for minimizing activity and emphasizing rest. If someone expresses that they believe the intervention won't work, give them information on its proven effectiveness. If someone says that they need to rest, educate them on the risk and explain how this will prolong their recovery. For example, tell them that each day spent lying down will prolong their recovery by up to 3 days. This helps them to make an informed decision about their rest and physical activity while in hospital. Also, reframe getting up as resting in a chair. It's a beginning, and it's better than staying in bed. If someone tells you they're too tired to engage in activity, recommend pacing strategies. Like, let's walk for a few minutes at first, then take a rest and walk again later. In my research, we found that some patients tended to use bed rest to save up their energy. Like, they said they would stay in bed Monday and Tuesday so that they would have all the energy they needed on a Wednesday when they had an activity. But we know from the space studies that this won't work. Bed rest will actually decrease their energy. If patients think an activity is too intense for them, guide them in starting slowly and progressing incrementally. Have them or their family member track their progress so that they see how they are improving. Also, explore their perceptions of the impact of the intervention on the patient's function, because beliefs change and motivation increases when people start to see positive benefits. If they're concerned about falling in the hospital, educate them on how to implement safe mobility strategies. For example, encourage walking at the bedside or with their family. So if you encounter older people who are self-limiting their activity while in hospital, you can use this strategy to learn if their underlying beliefs may be hindering their willingness to mobilize, and if so, how to respond to maximize their physical activity so that they can recover. Thanks very much for watching this microburst. I hope you find it helpful in your practice with older people.